next 2 hours, we're going to cover ED-based pathways for substance use and treatment availability. The idea of this is to make this as interactive as possible, which I know is not the easiest thing in the world to do in this format. But we've got the chat room, we've got a number of panelists here as well. Some of us have spent some time kind of thinking about how to go through these slides. And so I think between, Heather, Migichi, and myself, we can kind of monitor the chat room and watch for questions there, but also just feel free to jump in. I mean, ideally this will become a conversation, and especially for our panelists, I will guide some questions towards our panelists. But also if there's anything at all during this that you want to jump in and mention, please absolutely do just interrupt. We're ER doctors, so we're used to being interrupted a bazillion times a minute. I think there's actually some data statistic out there of like the number of times an hour we get interrupted, and it's like incredibly high. So it's not going to bother us if you want to jump in and say something. But the idea here is that we have all of our stakeholders who've helped us really think through and build out pathways that have made, I think, patient care much improved at Tampa General, and hopefully in the community eventually, compared to where we were even 3 years ago, 4 years ago, definitely from a decade ago, where these options just did not exist for patients to get the care that they need. So I'm really happy to have our panelists here from our stakeholder organizations and some of our internal panelists as well. And I know we also have some case management representation here as well, so that when we're working in the ED during a clinical shift, we can all be on the same page with what's the best approach for our patients and their care. So I'm actually going to start by turning it over to Adam Kobe, one of our third-year residents, who's going to kind of set the stage for us from talking about a typical type of patient we might see. So Adam, you want to take this?
Yeah, thank you. Thank you, Dr. Gillen. I think you hit the nail on the head when you, I just want to take a second and say, I think it's important when caring for these patients, you remember that addiction isn't a choice. And for a lot of these patients, it's unfortunately not their fault most of the time that they're going through this, and knowing that what they're going through is really, it's true suffering. And there's a lot of things that we can do to help. So from a patient's presentation, so this was a patient that I saw, an overnight pod 3 shift. This caused me a lot of mental anguish, and Dr. Lascano as well. It was kind of tricky to manage, and we'll get into it. So this was a 40-year-old female with a significant history of opiate use disorder and bipolar. She came in with, her chief complaint was withdrawing from heroin, and she wanted help with that. She uses 4 grams of heroin a day, she says, and her most recent use was 6 hours prior to arrival, and she used 0.5 grams. In addition, she also was going through a manic episode. She said she hadn't slept at all for 3 days. And so just basic review of symptoms, she was endorsing anxiety, generalized body aches, profuse sweating, nausea, diarrhea. But at the time, she wasn't experiencing any suicidal, homicidal ideation. There was no hallucinations of any kind. Next slide. Dr. Wilson?
Yep, I'm working on it. Sorry, Adam. Mouse issues.
I'm also working on my best Brian Samuel stash. So stash strong, Brian. And so on physical exam, she was afebrile, but she was very, relatively tachycardic, hypertensive, breathing 20 times a minute, doing well on room air. She was just on general appearance, very anxious appearing. She was not sitting in her bed. She wasn't laying comfortable. She would get up incessantly, walking around the room, going to the bathroom frequently. She couldn't sit still in any way whatsoever, rolling around in the bed. We had her on video obs, and people were just getting on me about doing something about it because they couldn't keep going into her room to stop her from grabbing at things or moving around. She was tremulous, she was yawning. Her skin, so she was, when I say diaphoretic, it was like she had just finished running a marathon, profusely pouring sweat. She did have pilar erection, obvious track marks in her AC fossa, which is where she did all of her injections. and her pupils were dilated. So at this point, I'm gonna stop my patient presentation. We'll move on to more of the presentation. We'll jump back to this patient soon. Stay tuned.
Yeah, and we're gonna leave this and let it sit for a second. Feel free in the chat room just to jump in and what you think might be going on with this patient. Why is she tacky and hypertensive and wandering around the room? What might be going on here? But we'll come back to that patient presentation. Just to give an idea of what we're going to cover today. Like I said, we're very fortunate to have some of our stakeholder panelists here. I want to just cover who that is. So people, one of the nice things about this, I think it'll be good to see the perspective of both the emergency department upstream and then downstream, our community partners, and see how much participation by the community has to go into making this patient care successful. And so we'll talk about some of those pathways we've built out that have allowed us to be successful for our patient care. Some are still building and some are still growing stronger, and some still have some work that we've got to, get through. But I think they're really growing rapidly. And we'll guide these with some case studies. And then throughout this, I'll scatter in some questions and answers for the experts that we do have here, just to make sure we hear their thoughts as well. Then we'll talk about I always like to, there's a saying in medicine, you never want to be the first to use a medicine or the last to use a medicine. And I do think in an academic facility, in a place that is as well positioned in the community as we are, that we want to be at least somewhere on the front end of that curve, closer, maybe not the first, but closer to the first, right? Innovative. But what's amazing is even as far along the curve as we are, there's always still some other group out there that's doing even more. So we'll talk about some of the really exciting stuff that's going on in other places, and some of the stuff that we're doing in the future as well. And then I think it'll be nice to wrap up with some success stories. We, sometimes don't get to hear about what happens with these patients, but we'll get to hear a little bit about that today as well. So you know who I am, so I'm going to skip that slide. Heather Henderson's here. Most of you know Heather. She directs our social emergency medicine programs, including these pathways. You also know her from the HIV and hepatitis C pathways as well. Has been really instrumental in building out most of these pathways, and is really our main liaison with the community, and then with our internal stakeholders too, like internal medicine, psychiatry, and case management, social work. So Heather's really the bridge between all of these programs and the guiding force in building out these programs. And of course, Jack McGeechee has provided excellent medical direction in building these out from the emergency medicine perspective, and what's safe to do, what can we do in the emergency department, what makes sense to do, what medication should we use, really kind of answering those questions as we build out pathways with both clinical and non-clinical colleagues. So thanks to Jack and his medical direction around that. For a while, Jack was actually our only buprenorphine waivered prescribing physician. And I think you're going to see today, we've made leaps and bounds and changes from where that was, from when Jack was our only provider. I know Dr. Hartney's going to join us for a little bit. I'm not sure if Dr. Hartney's on yet, but and I know some of our guests will probably jump in and jump out. But if you don't know Dr. Hartney, she's excellent. She's a psychiatrist with USF and Tampa General, and is the chief of psychiatry, the service line, and has been an excellent colleague to have to build out these pathways and to kind of think through things, I think, in a novel way, which we hadn't done before in our setting at least. And then I think most of from the ED side, know Bryant. Bryant trained in internal medicine at USF and now is taking a chief here. And Bryant has done a lot of work with us, thinking about things from the admitted patient side and also that transition to the community side for the complex medical patients. How do we build out pathways that make sense for those patients? And then also in the community as well. And we'll talk about some of the work that's going on around that too. Adam, I think most of you know, he just presented the case presentation. And Heather, is Alan on yet? Alan, are you here?
Yes, I'm here.
Oh, great. Okay, not to put you on the spot, Alan, but just so the other panelists know, I will give time for each of you to talk about, your work and what you do as we go through. I did want to stop here though and let Alan describe just sort of what the Central Florida Behavioral Health Network is and what he does. A, because I know he has to get off the phone in a little bit, and B, I didn't position him specifically into a slide. And so, Alan, if it's okay, would you just take a minute to explain your role and what the Central Florida Behavioral Health Network is?
Sure. Hey guys, thanks for having me this morning. Again, Alan Davidson, the Chief Clinical Officer for Central Florida Behavioral Health Network. Just to kind of give you a little idea, we are the managing entity for the Suncoast region and Circuit 10, which is Polk, Collins, and Hardy. So all the way from Pasco County, all the way down to Collier, over into kind of the Everglades and Hendry and Glades, and then back up. We are the funder for services for the uninsured. Again, as we call it, the Suncoast region, and then Polk, Collins, and Hardy. Our budget's about, just to give you an idea, it's about $220 million per year. We have about 80 providers that span that territory. There's 7 managing entities in the state of Florida. We are the second largest in land mass and the first in population. So as you'll hear today, we fund the providers, kind of as Dr. Wilson was talking about downstream, like DACO and ACTS. So we oversee those providers just to ensure that the uninsured around the state, and again, in this region in Hillsborough County, are getting the substance abuse services that they need.
That's great, Alan. Thank you very much for that. So I want to make it clear to our group and to some of the faculty that are here who've been working in this area for a long time, like Dr. Orban and Dr. Gillen, people who've been doing this stuff for a long time. We've really built out an incredible relationship with Alan and the entities that his group manages. And I think that's really what's made us successful, is some of those relationships we've been able to build out with Alan and all those associated groups. And so, Alan, I really do appreciate the partnership that we've built out over these past couple of years. I think it's been really great for the patients in the Central Florida area. So thanks for that. And also thanks for being here. So I think people have been doing this for a while, like Dr. Orban will attest, this is a world of difference than we were in a decade ago than what we're seeing right now with the opportunities we have for our patients. So thanks. I'm going to keep on moving. And again, I will come back to, as I do these introductions, I'll just do a little introduction now for some of our other panelists, but then I'll come back and you'll have time during other areas when we talk about your organization to say more. Desiree Meaton-Francisco is here as well. Thank you for being here. I'm glad you got on. And she is our Director of the Medical Assisted Treatment Services over at DACO. DACO is, of course, one of our significant community partners that we work with for addiction patient issues. And David Broughton also is here as well, who's the program director over at ACTS. So of course, another significant community partner we work with really on a daily basis with our addiction services. So I'm really thankful for Desiree and David being here. And again, I'll give you each time when we talk about your member organizations to say more about who you are and what you do. And I do, Heather, Samantha on? Samantha, are you here?
Yeah, she's here.
Okay, I do want to stop here though and introduce Samantha Reale and let her describe what this is. What is a lead peer recovery support specialist? I think most of the emergency medicine residents have now, and faculty have heard Samantha's name, met Samantha 3 o'clock in the morning, 3 o'clock in the afternoon. She's always working, it seems like, and really doing an extraordinary job of at her job. So I'm going to let her describe what her job is and what a peer is and why we're so fortunate to have a peer in our emergency department like we do. So Samantha, do you want to say a few words? You might be on mute, Samantha, sorry.
Yeah. I should have checked that first. I had to do the video. Well, my name is Samantha Reale. Most of you have seen me around because I make myself known. And a peer is someone who has experience in the patients that we work with. So I am in recovery. And I've been this population. I am this population. I've been to the hospital and attendings and doctors don't know what I'm there for, and they really, don't know how to help me. And this pathway is amazing and it helps other patients. I link them to Care with Axe or DACO. I'm there to help you all if you have any questions. And I believe that is all, Jason.
That's great, Samantha. No, I really appreciate it. You know, we started having conversations about having to appear in the emergency department probably about 3 years ago now. And, you know, I'll be honest and admit I was a little skeptical about the concept of a peer in an emergency department and what that role could provide. And so like Heather does, she presented a lot of literature to me that clearly told me I was wrong. So I looked at the literature and realized how wrong I was, and you know, really glad that we continue those discussions forward. And again, through the leadership of ACTS and David Broughton and DACO and Alan Davidson, we've been able to supply the peer, you know, his community-funded peer who is in our ED, working with us to link patients to the appropriate site and place. Really in a way that, you know, that speaks through lived experiences in a way that probably none of, you know, that we may not be able to do, at least in our clinical roles while we're working clinically. So it's been absolutely incredible to have Samantha, and hopefully as time moves on, our goal is actually to have a second Samantha. I don't think Samantha's clonable, but a second peer at least, and that would be the idea. And you know, tell me if I'm wrong, Samantha, but I think your role is based in the ED, but really has grown to look at patients throughout the hospital setting, and you know, find patients on the inpatient side, and wherever is appropriate to follow those patients through and make sure they get the right care in the community when they leave the hospital. Does that sound right?
Yes, I've also followed, I just recently followed a patient who was incarcerated, and his mom reached out to me, and I went to the court date, and I was able to get him out and transport him safely to DACO, and he is still currently in, he's active at DACO, and there's actually a couple other patients that we've linked to care there as well, which has been amazing to follow them through and see their progression.
Yeah, that's incredible. And I think bringing those stories back to us, Samantha, is really rich for us. And I'm watching the chat room right now, and you've clearly made an impact in our program, just looking at the comments that the residents and faculty are making. So again, really appreciate all the hard work you're doing right now. And I know you're probably doing the work of 2 people right now. And I know Heather's working and Alan, everybody's working on, you know, making a somewhat of a clone of you if possible. So I'll just keep moving on. All right, let's get into some clinical information. So I'm just going to run through these. We're not going to deep dive into each of these. I just want to kind of set the stage. And these are just composites. I think everybody who does clinical medicine, you know, is definitely emergency medicine is going to recognize these patients. Brian's going to recognize these patients too. And what I would like you to do, you know, I might ask a couple little questions here as we go through these cases. If you wouldn't mind just chatting in the chat room, the answers, you know. So 30-year-old male presents active IV drug use, last use 1 hour ago with abscess. What kind of, I mean, is this a patient that we, vital signs are normal. Vital signs are normal. Patient presents, you know, with IV drug use, last use an hour ago. He's got an abscess. It's easily drainable. Any next step thoughts here? And you can just throw them in the chat room. Do we Marchman Act this guy? Do we send him to ACTS forcefully? Do we talk to him about drug use? Do we call the peer specialist? What are some thoughts people have?
Do we give them Suboxone right now?
Do we give him Suboxone right now?
Do we admit him? Do we send him home with instructions to come back? Are we going to send him home with home induction instructions? All possibilities.
My money yesterday, we were talking through these as our group, and it was the first answer will be call Samantha. And that looks like the first answer.
Usually
that's
good answer. Yeah.
Yeah. You know, and that's an okay answer. I have no problem with that answer. Is he wanting treatment? That's a great question, Tiffany. So maybe you talk to this patient about, do they want treatment? And you know, if the patient says they don't want treatment, are we done with this patient? Right. I mean, Brian's shaking his head. No, I think that's probably correct. I mean, I think this patient may not want treatment today, right? But we do have a team of people who
yesterday I get in the mail a check.
Is everybody on the mute who's not talking? I'm hearing voices in my head otherwise.
I heard him.
Okay, cool. So yeah, maybe this patient doesn't want treatment right now, but that does not necessarily mean we're done with the patient. So that's a great point there. It may still mean the next action step is the same. Are there any other clinical action steps we might want to take? Now, how do we know if this patient's, even if they wanted treatment, how do they know that how do we know if it's okay to give that patient Suboxone right now versus later? How do we know it's safe to give Suboxone right now? So we'll consider those. I'll come back to those. 30-year-old male found in a vehicle on the side of the road, unresponsive, given a milligram of Narcan, responds, now is in the ED, seems awake and alert. I don't know what happened earlier. I don't know. Well, you were found in your car and you're unresponsive. Oh, okay. You got Narcan, he responded. What are thoughts about this patient? Do we Marchman act him? Observe, okay. Observe in what? Are we going to observe and send to a facility? Are we going to observe and admit to the hospital? Are we going to give them Suboxone? What other kinds of things might happen with this patient? Just keep moving through these. You can keep on putting things in the chat. 30-year-old female, she took a pregnancy test at home. The pregnancy test was positive. She comes into the ED basically telling you that she had a pregnancy test that was positive, but she uses heroin. She wants some help to stop using heroin. What do you do with this patient? She's probably first trimester, right? She just took the pregnancy test at home. Okay, Dr. Okonkwo says, don't give Suboxone too early. You want to wait until they have some signs of withdrawal. Shoot for CALs of 8 or greater. Okay, so CALs, that's a new term we haven't seen quite yet. So maybe we calculate a CAL score for some of these patients, which is a clinical opioid withdrawal score. So maybe we calculate a clinical opioid withdrawal score, which will help us know when it is safe to give a medication. Andrew Thomas has introduced another new term. So we've talked, Jack mentioned Suboxone earlier, Nola Okonkwo mentioned Suboxone, and now Andrew's brought this other term, Subutex, and Subutex is the form of buprenorphine that is probably preferred in pregnancy. So a couple good observations here. Maybe do a CAL score, maybe give a different medication. Perhaps we have an OB pathway for this patient. 30-year-old male arrested for parole violation. So now he's brought in, he's got Hillsborough County Sheriff's Officer next to him. He's in law enforcement custody. They brought him in for medical clearance because the patient told booking that he uses fentanyl and heroin multiple times each day. What do we do with this guy? I mean, it looks fine, right? He's got normal vital signs. Maybe we did a CAL score on him, but it seems pretty normal. But now he's pretty significant parole violation. Sounds like a felony parole violation. Yeah, so Morgan said he's going to withdraw at some point here. So what do we do with that? So maybe there's some options for law enforcement pathways for people who may withdraw. So we'll come back to that. 30-year-old male found in vehicle on the side of the road. So sort of sounds like number 2 so far. He's unresponsive. He's given a milligram of Narcan. He's initially responsive, but he looks different in the ER. He's not the same guy as number 2. Instead, this patient is hypotensive, respiratory rate's 8. Is this one different than number 2? How so? Yeah, and great. Dave Bryant from ACTS brought up that Suboxone, the difference between Suboxone and Subutex is the addition of naloxone in the Suboxone. Thanks. So yeah, this guy, right? So this guy, Morgan brings up, we probably need to resus more. And so what does resus mean for this guy? He's hypotensive again. His respiratory rate's 8. He got Narcan earlier. Yeah, so ABCs. He's probably going to get more Narcan. So he seems like a different patient than number 2 in some ways. But does that mean we don't enroll him or think about him or make sure we establish some contact with care with these pathways of this patient? He may not get discharged, over to one of our partners today, but he's going to need some help at some point. If he does go home later, what should he go home with? Right? These are things to think about too. All right, 30-year-old male with recurrent abscess on forearm, denied IV drug use on previous visit, but here he is again. He again tells you, no, I don't use IV drugs. Appears to have multiple injection sites on the arm. So kind of sounds like number 1, right? pretty stable sounding patient with an abscess on the forearm. Seems like an IV drug use history. So this Dr. Pleasant's question, basically. So maybe patient 1 is more active and ready to engage in care. He's admitting to IV drug use, but maybe patient number 6, is the other patient Dr. Pleasant was thinking about, where the patient's not quite ready to engage. What do we do with those patients, and how is it different? 30-year-old male, new COVID infection. SATs are 92%. He's hypotensive when he got here. But you know what? He also wants to stop using IV drugs. So again, this patient probably not going to go home from the ED today, even with our Mosmo devices and all the other things we're using these days. Probably going to need a little bit of medical care. When he gets discharged, it's going to be a complex medical patient. What do we do with these complex medical patients who have and want help with IV drug or opioid use disorder?
Above and beyond that, what do we do with people who are infectious with COVID? That's a good consideration as well.
Yeah, and
you can't stand in the dispensary line if you're on isolation precautions, right?
Yeah, that's a great question. And so this is a medically complex and challenging patient. And so we'll come back to some ways we might handle medically complex patients as we go through this. But that's right, Jack. And what you mean by dispensary line, of course, is that methadone. If this patient were to get methadone, he would need to show up for dispensation for the methadone.
Sometimes with
methadone.
Suboxone too.
Yeah.
Sometimes Suboxone is passed over the counter, but maybe that's a little too granular.
No, point's great though. The point you're making is that he can't go to a treatment facility every day and show. We've had trouble from Tampa General Hospital. This place that's seen all these COVID patients, and as an innovator in care, we've had trouble finding places for our patients to go with COVID illness for our research studies, right? So we have come up with some pretty clever ways, and we've had trouble finding places for patients to go just COVID, just need clinical care. So Brian's been involved in a lot of the telemedicine setups for these things, and we are actually seeing a lot of ED research patients now through telemedicine or at the COVID clinic at 30th Street. But it's been a real challenge in this community to find primary care doctor locations, our own hospital, locations to see COVID positive patients downstream of their illness. 30-year-old male uses Xanax and crushes and snorts oxycodone. He actually wants some help with this. So it sounds like he's got a couple of things going on. So he's using both opioids and benzos. This would be a poly substance use disorder. So what do we do with patients who have poly substance use disorder? Is there a pathway for those patients? Are there any extra considerations for a patient who takes benzodiazepines when we think about drugs that can be used for use disorder? And now this last patient here is a pediatric patient, 15-year-old male, has admitted to crushing and snorting oxycodones, recently even started injecting drugs, as presented to the ED. What are the laws and rules around adolescents and pediatrics? Do we need to do something different with this patient? Are we allowed to treat this patient? Are we allowed to engage this patient in a discussion about treatment without their parents present? Are they able to take buprenorphine? Are they able to go somewhere? Do we have a place for them to go? So we'll talk through some of that. So those are just clinical cases that give us some, places to go in these conversations. Does anybody think I'm missing? I mean, do all these look pretty familiar to those of you who practice medicine, or those of I think all of us on this call? I mean, do these patients look pretty familiar to us? Right. I mean, I think these are composites of people we've all seen. Are there any specific scenarios anybody think are missing here that they want to throw out as well? Any other acute types of presentations we might see that I missed here? I think this covers quite a few different scenarios we might see. So we can use these scenarios to talk through our pathways and see if we have different pathways for these patients. And, I'm going to jump around a little bit as I see things in the chat. And Dr. Okonkwo just mentioned that we have free MAT training, which is a great point. So you can't get your Data X waiver until you have your DEA. And so a data X waiver is a special tag on your DEA license. And we'll talk a little bit more about it in a second, but you can easily take the course and be ready to apply for that once you have your DEA. And it's used to be a kind of a in-person, expensive, time-consuming, kind of boring class, which is why no emergency medicine doctors took the class, right? So if you go back 5 years and you Googled who has a data X waiver, and a data X waiver means you could prescribe buprenorphine. You Googled who has a data X waiver in Tampa, or you actually went on a website, there was a website for it, there'd be, you know, a handful of outpatient psychiatrists, addiction medicine specialists, okay? That's who would have it. But now the difference is that the virtual ability to take that class, but I think also for emergency medicine, the involvement of emergency medicine in creating the curriculum for that class, or even just acute care medicine, I would say, and creating a curriculum for that class, I think has really brought in other people. You know, so when I took the course, right, it was a lot of emergency medicine scenarios and emergency medicine faculty, you know, teaching it, which you didn't have that option before. And then of course, now as we build out pathways, the relevance of having a data X waiver is increased as well. So the why would I prescribe buprenorphine? That answer has been made, where that I don't think there was a good answer to that 5 years ago. So yeah, to our seniors, you can take the class for free, and then you can apply for your waiver as soon as you're done. Jack, I'm going to turn it over to you. We're going to I think it's important to cover, we're talking a lot about buprenorphine and Subutex and Suboxone and methadone. So I think we should spend a few minutes on just the science of the pharmacology here, just to make sure everybody is on the same page with how these drugs work. So I'll turn it over to you, Jack.
Yeah, thank you. So as I'll keep this brief, as I know that, you know, basic sciences are nobody's favorite. But one of the key facts you need to know about buprenorphine is that it is a partial agonist at the mu receptor. What that means is that while it binds to the receptor, it exerts both an agonist and antagonist effect on that receptor. As you can see in the little illustration there, the perfect spiky little green morphine ball fits very well into the receptor and activates it completely, whereas the incomplete and imperfect little buprenorphine cloud of particles does not fit very well, and therefore does not fully activate the receptor. In truth, the idea of classifying drugs as full agonist and partial agonist is a little bit of a misnomer, as there is no perfect agonist. Even morphine, to some effect, has partial agonism. It's just that partial agonism is so tiny that it's essentially, in clinical practice, completely outweighed by the full agonism. Next slide. So the practical consequences of this is that the partial agonism creates a dose ceiling on the respiratory depression. If you can think that there are two graphs, right? The agonism activity according to concentration and the antagonism activity according to concentration. You add those two graphs together and you get a graph that plateaus. And that plateau, right, is about 32 milligrams. After 32 milligrams, the agonism is balanced by the antagonism, and you really don't get much more of an effect on respiratory depression, which is nice because that means in adult patients, it's very, very rare for them to overdose on buprenorphine alone. As far as I understand, there have been no overdose deaths attributed to buprenorphine alone. The only ones in which buprenorphine plays a part are polysubstance overdoses, particularly with benzodiazepines. Now, I also want to add the caveat that this does not apply to children. Children that are inadvertently exposed to buprenorphine products can develop respiratory depression, sometimes very significant respiratory depression. And so you need to be very cautious when you have a child that's been exposed to Suboxone. And usually what happens is they find a pill or a film that the parent has left out and they stick it in their mouth.
Sorry, Jack.
That's okay. I'm ready for the next slide.
Okay.
Yeah. Now, it's important to distinguish between agonism and binding affinity or avidity. Not quite the same thing. You can have a substance that binds very avidly to a receptor, but is a relatively poor agonist. And the effect would be that that would prevent other agonists from binding at the same receptor because they lack that binding avidity. That's exactly what buprenorphine is. Buprenorphine binds more avidly to mu-opioid receptors than almost any other drug in the family. As you can see on this graph here, on the left-hand side, it indicates greater binding avidity, and the bar width is just the confidence level of the values. As you can see, they vary quite a bit between studies. But buprenorphine is the second from the top there, right below sufentanil. You can imagine this, describing that buprenorphine binds more avidly than almost any other, including methadone, oxycodone, morphine, tramadol, and also naloxone, surprisingly. Buprenorphine actually binds more avidly to the receptors than naloxone, which is why the combo products don't make a lot of sense pharmacologically, as you wouldn't expect the naloxone to be able to outcompete the buprenorphine, even if it were injected. Thankfully, though, buprenorphine has a respiratory ceiling, so the fact that it binds more avidly to the receptors than naloxone is not typically a problem in clinical scenarios. Next slide. There we go. So the consequence of these two properties of buprenorphine mean that you can put a patient in what is known as precipitated withdrawal. If you administer buprenorphine while there's still full agonist in the system. So to get precipitated withdrawal, there's a couple of criteria that have to exist. Number one, you need a patient who is dependent physiologically on opioids. Number two, they have to have a full agonist in their system at the time. And number three, you have to give them buprenorphine. So once all three of those intersect, the patient may very well develop precipitated withdrawal. And what essentially is happening is those receptors are being attacked by the buprenorphine. The buprenorphine binds more avidly than almost any other opioid, and so it kicks off those full agonists, and it binds. However, due to the partial agonism, the receptor is not fully activated, and you go from being 100% or 80% high to like 20 or 30% high, and it's the absolute difference that makes the precipitated withdrawal. Now, say if you had a person who was not physiologically dependent on opioids, you give them morphine first and then the Suboxone. It's not going to precipitate a withdrawal because they wouldn't have gone into withdrawal in the first place if you had, taken away the morphine. Conversely, if you have a patient who is dependent and you give them the buprenorphine, but there's no other agonist in their system, they go from 0 to 20 or 30% high, right? And now you got a positive absolute difference. They're not going to be put into precipitated withdrawal. So that's why it's so important to ask the patient when they last used an opioid, what that opioid was, and to also carefully assess their withdrawal symptoms so that you can objectively score them. And what this shakes out to mean in practice is that for short-acting opioids, we typically recommend 12 hours from the last dose. And short-acting opioids are morphine, oxycodone, hydrocodone, Dilaudid, heroin, fentanyl. But for long-acting opioids, which are typically the extended release opioids like OxyContin, MS-Contin, we recommend 24 hours since the last dose. And then in the case of methadone, which is special, we recommend 72 to 96 hours since the last dose to avoid precipitated withdrawal. Next slide, please. Speaking of methadone, in contrast to buprenorphine, it is a full agonist, meaning it has no dose ceiling on respiratory depression. If you keep giving a patient methadone, they will get progressively more respiratory depression to the point where they arrest. It also has a half-life somewhere around 48 hours in the average adult, but that varies from person to person. You won't put somebody in precipitated withdrawal with methadone, but it takes some time to get the right dose. And you also cannot start with any more than 30 milligrams in the first day. And for a drug where the average dose is anywhere between 40 to 200 milligrams, you can imagine how difficult this is to titrate with a 48-hour half-life. Those are some of the reasons why, for our program, we recommend Suboxone rather than methadone. It's also due to the fact that it's much easier to switch from buprenorphine to methadone than the other way around, right? Can anyone describe why it's difficult to switch from methadone to buprenorphine, knowing that methadone has a very long half-life? I'll let you guys discuss in the chat. There's also some legal issues.
Morgan asks, is maybe at the affinity? That was his question there in the chat as to why.
Yeah, so the issue is that it has a half-life around 48 hours, right? And so patient will start having withdrawal symptoms, but they'll still have a significant amount of methadone in their system. And if you don't wait until they truly are in withdrawal and most of the methadone is out, if you give the buprenorphine, you're gonna switch them into precipitated withdrawal. And that's why it's so difficult to switch over that direction. But the other direction is trivial. You go from taking your dose of buprenorphine yesterday, today you have a dose of methadone. That's simple. Unfortunately, methadone is a drug that is saddled with a lot of legal issues just due to the history of drug treatment in this country. It can only be dispensed from special regulated facilities if it's to be used for opioid use disorder. And there are also some very specific regulations on how dosing may occur, the consequence of which is that if we start a patient on methadone in the hospital and we titrate them up to an acceptable level, say like 50 to 100 milligrams, at discharge, when they follow up at the methadone clinic, be it DACO or some other clinic, they can only get the 30 milligram dose the first day they present at that clinic, even though they were discharged on a higher dose. Again, this is due to complicated and I think ultimately unnecessary federal regulations, but they are the regulations that we have to practice by. So for that reason, we strongly advise our providers to avoid dosing with methadone, and almost always you should really just do the Suboxone or Subutex.
Yeah, so all of our pathways will be buprenorphine based. This does differentiate from chronic pain management, which sometimes does utilize methadone. So this is not a general blanket statement to say never give methadone in the ER. We know some patients do come in with chronic pain management needs that require methadone. So just separate those two things out, and we'll return to methadone for pain management in a lecture later. Jack, what happens if we do precipitate withdrawal? What do we do?
So there are two schools of thought on treatment of precipitated withdrawal. Probably the most common school of thought is time's really the only treatment. That unfortunately, if you give more bupe, you're not necessarily going to help that person, being that it binds so avidly that all you're going to get is just more bupe in the system. It's going to stick around for longer. And you're never going to get more than that 20-30% receptor activation of the mu receptors, right? You'll never get past that intrinsic partial agonism. The other school of thought is that, well, maybe the patient is just underdosed, and so we should try and increase go stepwise and try and increase their dose to see if we can get their symptoms under control, because it's not necessarily going to get worse. It's just going to last longer. And I think that the answer is probably in between the two. There are definitely some patients who their withdrawal is just inadequately treated, in which case, feel free to give them more. You can go all the way up to 32 milligrams, as I mentioned. And even if you go past 32, you're not going to kill anybody with buprenorphine alone. But also useful would be non-opioid adjuncts, right? So if you've locked down your opioid system, right? And I think of it this way, like they make these certain keys that break off in the lock to what they call a killer key, right? So you break it off in the lock and you disable that lock, right? So I think of it that way, like somebody put a killer key into your opioid receptor system. Well, now you got to use your other means of egress. So do you break in the window? Do you go around to the back door? Do you go through the garage? So in these cases, give a drug that doesn't work on the opioid system. Gabapentin can be helpful when it comes to the anxiety component, and also some of the autonomic symptoms. You do have to give a pretty hefty dose of gabapentin. I would recommend like 600 or 900. Again, gabapentin is really safe. You're not going to kill anybody with 600 milligrams gabapentin, especially if they're in withdrawal. To help more with the autonomic system, autonomic symptoms, right? Like tachycardia, sweating, piloerection, chills. Clonidine can be very helpful. So as long as their blood pressure can handle it, right? And most of these people are going to be normo or hypertensive. Give them a dose of clonidine, like 0.2 PO. Then you can slap a sticker on them of like, 0.2/24 or something like that. And then also other symptomatic targeted therapies like ondansetron for nausea and vomiting, Toradol or acetaminophen for muscle aches and pain, fluids to replace the fluid losses. And in real extreme cases where they're just completely agitated and you can't talk them down or calm them down, you might consider giving either a benzo or some haloperidol or Seroquel. But I'd be real cautious with the benzo, especially if you've maxed out your buprenorphine at like 32. I'd be real hesitant to give that person Ativan.
Yeah. And just so people know, for our NIDA grant, precipitated withdrawal is considered an adverse event. It doesn't mean that that's the end of the world. It just means that it's an event we have to document. So we'll be developing a pathway or protocol, I should say, a specific protocol for what to do if we, as we move to differentiating underdosing versus precipitated withdrawal, and what that means for the study and what that means for clinical practice. Bryant or any of the other providers here or anybody from the community partners, anybody else want to comment on either the pharmacology slides we've talked about or the precipitated withdrawal effects? Anything that anybody wants to add here?
One of the things that we do in the clinic is oftentimes we have patients who've already been on buprenorphine before. They've done induction before, and we do home inductions. So we'll actually send them out, have them fill their buprenorphine script, at either TGH or one of the commercial pharmacies. And then we'll tell them, we'll give them the kind of list of symptoms to expect with withdrawal, but oftentimes they're more experts at knowing when they're in significant withdrawal rather than us. So we tell them that essentially once they're starting to feel dope sick, that they can take their first dose of buprenorphine.
Yep. And that I want to second what Bryant said, that really just listen to your patient. If you go back to reassess them and they tell you, I'm still having cravings, they look better to you, but they tell you, I'm still having cravings, I still feel like I'm in withdrawal, just give them the second dose. Believe your patient. They're not trying to fake to get Suboxone. It doesn't get them high. And you just want to make sure you treat their symptoms appropriately.
This is
Okay.
Dr. Hartney with psychiatry too. I just wanted to add that with the clonidine, often folks are thinking that that's helping with autonomic symptoms of withdrawal, and instead opioid withdrawal rarely has autonomic symptoms. That instead it actually blunts the adrenergic fibers as they come out of the dorsal horn. So it actually helps with the pain. So when you're using clonidine, it's very important not to just use it PRN, to instead schedule it or give a one-time dose in the mouth and then use the patch like was mentioned.
It's great.
Wow.
Dr.
That's
Hartney,
great.
thank you.
I didn't know that.
Dr. Hartney, any other thoughts about the medications we've talked about, or I don't know if you saw any of the cases we talked about so far, any other thoughts that you have as we go along?
No.
Great.
No, not.
Great.
Yep, I'm listening along. Thank you.
Awesome. Great.
Hey, Dr.
Any of our,
Wilson,
yes,
this
please.
is Alan Davidson. Hey,
Hey, Alan.
and Dr. Shu, we've been having a conversation offline. These medications can be paid for free over at ACTS and DACO if you're having patients that are struggling with funding. So if they're uninsured or underinsured, they can go over there and get these meds for free.
Yeah, and as we talk about our pathway build outs, the idea is that our pathways will link in the patients to the appropriate site, whether that be ACTS or DACO or the USF clinic, but make sure they get to the right place where they will get medications that they can either afford or get through some type of subsidy. So I know that David and Desiree both have those programs, and hopefully we're getting our patients there through Samantha and the peers. But yeah, the nice thing I think that's important for us as we think about our pathways is that if we use buprenorphine, whatever way we use it, Subutex or Suboxone, then our experts over at the community sites can make the decision as to whether they should stay on, what type of buprenorphine or methadone. And some of that is clinical decision making, and some of that's funding decision making. Bryant, David, Desiree, anybody else want to comment on anything about that decision that takes place for the patient when they get to the site as to whether they go on buprenorphine or methadone, and how that decision maybe is made?
So at ACTS, we don't offer methadone, so it's really not a choice. We do offer Vivitrol, but that's very difficult for us to get people who are, who are struggling with opiate use disorder on Vivitrol because of the 10 to 14 day wait period. We do offer it at no cost or on a sliding fee schedule, the Suboxone. We generally dose for the first week, in person, and that's as much for two reasons. One is it gives us a chance to continue to check their drug screens to make sure that we don't have other substances that we're contending with, and secondly, for the docs to moderate the dose and get it at the right level for folks. And then after a week, then we'll give them a prescription, or we'll give them a week to take home. And then if they continue to do well, we'll expand that to 2 weeks and eventually up to a month.
Great. And Desiree, did you want to add something as well from DACO?
So I did. What we do is our intake is two-part, and the two-part is a clinical and a medical intake. So it's really based on what the patient presents as. We take a lot of different factors into consideration, such as psychosocial indicators of maybe stability and being able to maintain on a medication, also their use patterns and how long they've been using and where their tolerance is at. We offer methadone, Suboxone, Subutex, buprenorphine, and Sublocade and Vivitrol. So the patient gets talked to about their treatment options based on all different medications, and it's really a decision that the individual and the provider make in conjunction with what the clinical record looks like.
That's great, Desiree. Thank you. Great. So I'm going to keep on moving forward.
Jason, before you
yes, please, Jim.
Jack, you were saying that even if the patient tells you they're in withdrawal and their CALS score doesn't indicate they need Suboxone, you still give them Suboxone, right?
Yeah, if the patient tells you, I feel like I'm craving, I'm worried I'm going to go out and use, just give them the Suboxone. I would 100% trust them. I really want to reiterate, for somebody who is dependent on opioids, sublingual Suboxone really does not get them high. They are not doing it because they want to get high or they're trying to cheat you. They're doing it because they're asking because they really do have symptoms. And that's one of the major reasons why we give it in the first place. So I wouldn't let them leave until they feel like completely comfortable. And they should, unless they've been doing like a gram of fentanyl IV a day, which I have seen. You know, the patient is most likely going to be stabilized by the time they get to 16 or 24 milligrams of Suboxone. For the rare patients who are using extremely high doses, like the guy injecting a gram of illicit fentanyl a day, unfortunately, that patient Suboxone may not be able to get to a level of substitution that's going to actually make him comfortable. That may be a case where somebody would benefit from methadone.
You know, I'm glad you're saying that, because what I run into is, like, I give the first dose and patients still feeling it, and I'll get pushback saying, you know, the COWS score doesn't indicate a second dose. So I'm glad you're.
I'm just curious, who's telling you that?
I forget. I think it was early in the program where we weren't fully on board.
Okay.
I haven't gotten that lately, but in the beginning.
I definitely hope the RAs don't say stuff like that. Because at the end of the day, it always comes down to the physician decision. You're the physician, so you're the one.
Let me just put a plug in for that too, Jack. You know, our research assistants have been pivotal in helping us with this program. But I do want to remind everybody that the job of the research assistants is really identify and help create the beginning of the initiation of that linkage and do some of the hard work that it takes for these patients to help hardwire the process in. They are not experts in addiction, and they're not experts in clinical medicine at all. That's really, we're the experts in clinical medicine, and more of us have decided to gather the extra education to at least learn the emergency management of addiction and withdrawal. So what I would please just remind all the physicians and residents providers here is that, and the case management group too, is that the job of the RAs is to say, hey, this is a patient that looks like they make sense, to go in, even calculate the clinical withdrawal score, which is once with some training, a fairly, it's time consuming, but easy score to calculate. And so we have trained them to do that. And then to start kind of through your guidance, the liaison process of what you need done. This patient needs a form filled out for ACTS or for DACO. This patient needs this, this form filled out. I'm going to work with social work and kind of keep up with the phone calls that are going back and forth with the community partners. And they're in the, like Jack said, they're in the background screening 24 hours a day, 7 days a week, and they have lifelines. So if they're getting either, some conflicting information or there's a clinical question, they have lifelines with us. They can go to Samantha or the peer. They can go to Heather, myself, or Jack. So we're actually building out even a more formal type of call schedule for the program if one of us aren't working clinically or Heather's not available. So they have lifelines for these things. And also, of course, some of these things don't come in with a pretty bow tied to them saying I'm withdrawing. And so they're not going to see every patient on a tracker. And so we still have to recognize patients who may need help as well. Does the interchange at night when pharmacies are closed and no access to them if we want? That's great. So we'll talk a little more about the pathway a little bit, but there is a nighttime process. We're going to be giving that first dose of buprenorphine, which will last the patient, into the next day, given the half-life of the drug. And then we have some transportation options and things like that as well. We'll talk about when we get to the actual nitty-gritty of the pathway. Great question. Any other thoughts about the pharmacology, the drugs themselves, before we move forward?
The films work better than tablets, so are we able to get films all the time in the ED right now?
So commercially speaking, like in most commercial pharmacies, they do not stock tablets anymore. All the drugs are film. At our pharmacy, I believe we're still using tablets because we still get them from that. I guess that's our preferred provider, but in the community, you'll see that they use almost exclusively film.
David?
We only give tablets because they're a lot less expensive. We can buy an 8 milligram tablet for $1.30, and the film is like 3 times that much.
So I think that the theme is that institutions tend to use the tablets. Community providers tend to write for the films. But there's also another product that is only available as a tablet, and it actually has different, slightly different milligram dosage because they've proven that the sublingual absorption is better. I can't remember it off the top of my head. I don't know if it's still available, but you may see that from time to time. If you see like a 5.7 milligram buprenorphine product, that's what that is.
Before we get off that topic, I might just add that we do also offer Sublocade in some rare instances. We've only got about 5 people on it because it is so expensive. But for folks who have had a history of failures on Suboxone, then sometimes the Sublocade offers an opportunity. And what it does is, it is a long-acting injectable, and it keeps the buprenorphine level at about 2.9 milligrams. It keeps it pretty constant, as opposed to Suboxone, which can go up and down depending upon metabolism and so on. So, and it also, even though as you continue the dosage, continue over a couple of months, it is almost kind of self-titrating, because it will, it will actually last, even though it's meant for a month, it will actually go out about, 5-6 weeks. So it has a lot of benefits, but again, the cost is the issue unless people have insurance.
That's great. And we're going to return to injectables when we start talking about our NIDA grant as well. There's going to be an injectable option in the ED as well. So we'll talk about that when we get there. That's great, David. Any other comments about the pharmacology before we move forward? Well, great. That was great discussion. I appreciate it. It really does make this go a lot better with the discussion. So thank you for participating and engaging everybody. So I'll talk a little about this, these papers. So I just want to reiterate that, a decade ago, these patients, we really didn't do much of anything for when they presented to the ED. We might give them, I think how Jack described it, I kind of like the ERES approach. We might give them some relief of some symptoms with some clonidine or something, but we weren't really looking at treating opioid use disorder or any substance use disorder as part of emergency medicine. But, those who've heard me kind of give the spiel, my general spiel is that we, the patients who show up in the ER decide what the role of emergency medicine is, because they're the ones who show up. We can try to create a structure of what counts as emergency medicine, but we don't get to pick it at the end of the day, they pick it. And so the frequency of substance use disorder that shows up in the emergency department, right, is incredibly high. And so at some point there becomes just sort of a gap in what we're trained to do versus what we actually do, and where that responsibility lies to change training, because the patients aren't going to change. It's been that way for 50 years of emergency medicine. It's going to be that way for forever. It's going to be that way forever. And so, at some point, people finally figured out maybe we should become experts in the emergency management of opioid use disorder and substance use disorder, just like we're experts in the management of other, types of medical pathways. And so I think for me, I think most emergency medicine as a field, and even acute care medicine, hospital medicine, I would say, were these landmark trials that started to come out that really demonstrated there is a role of acute management of opioid use disorder. That's not something you can say, look, there's something I can do about it right now. I don't really need to act on this right now. It can be pushed down to downstream providers. That really hurt our downstream providers, I think, because they lost a lot of patients they could have had from us in the past. There were no bridges built. There were no opportunities to link patients to places like ACTS and DACO and our other service providers out there. And they really had to just rely on other ways, either the legal system or other ways for patients to show up at their door. But as we've medicalized this disease process, now we have all the things that would normally happen that we demand as emergency medicine physicians and hospital medicine, people, that we have somewhere to send patients and some kind of pathway for these patients. And so just like a cardiology visit or anything else that needs to happen after an ED visit or a hospital stay, we've demanded the same thing out of this, and it's really grown out and scaled up pathways. So GLD and Afrio is sort of the the grandmother, the mother, whatever, the birther of a lot of these programs at Yale. The Yale group really has led the way in a lot of these programs. This JAMA study, the emergency department initiated buprenorphine, naloxone treatment for opioid dependence was the game changer trial. That's where it really did show a difference that acute management of these patients with AD has a downstream long-term impact on the patient's life. So it actually saves lives later. So mortality improvement, but also engagement and care improvements. The first thing she demonstrated was there was a engagement and care improvement by giving people buprenorphine. And then later they followed that up with actually showing a mortality decline. And they showed up in animals as well. And so I think it's really changed the face of how we deal with this from an emergency medicine standpoint and from an internal medicine standpoint. And disclosure, Catherine Hawk, who's on this JAMA paper, is our site director for Tampa General's NIDA grant. So she's my supervising PI in the NIDA grant that I have with Heather and Jack. And she falls under Gail D'Onofrio as the main PI on the NIH study that we'll talk about, the CTN 099 study that a number of our faculty members are also investigators on as well. So that's kind of the group there. And again, the thing that they showed was that there was a difference in just sending people to, hey, you know, you've got opioid use disorder. I'm so sorry you have that. There's not much I can do about it. Why don't you go off and see Axe or DACO after you leave here, versus, you know, this is really important that we talk about this addiction you have. Here's, you know, what this means. Here are some options. That's the brief intervention. Hey, you should really stop using drugs, and I'm going to send you somewhere. So that was kind of, I'd say, you know, even brief intervention was probably a step up from referral, but these were sort of the mainstays of how people were approached, you know, when I trained up until at least the last few years. And what her study showed was there's really no difference in either of these. The brief intervention didn't really add too much over referrals to a downstream clinical site. But what did make a big difference, what made a huge difference, was induction of buprenorphine in the ED. So ED-initiated buprenorphine. And I'll just expand that now, given the data we've seen at this point, that would be acute hospital medicine induction of buprenorphine. So whether it happens in the ED, if the patient's leaving or coming into the hospital, whether it eventually happens on the hospital floor, whether it happens in the OB suite, wherever. The point is that acute management with buprenorphine in a hospital acute setting, including the ED, has really changed the game. These patients are much more likely to be engaged in care, 74% compared to about 50% with the other two approaches. These patients are much more likely to be engaged in care a few months later. And again, data has come out since then that shows an actual mortality decrease. So how many other hospitals are offering a MAP pathway? Not very many. There are a few out there. One of our former residents, actually, Zach Terwilliger, if everybody remembers Zach, who's on from the ED side, but Zach has actually been tasked with building one out over in Melbourne. And I know he's reached out to Jack and I with, you know, some clinical questions about how to build this out, but really not very many. Yeah, right. And St. Anthony's, I know, is building one out as, is that on St. Anthony's? I think so. Yeah, building one out as well. This is a rare thing in emergency medicine. Heather, Jack, and I have given talks at FCEP and Symposium and, you know, all the state emergency medicine conferences. And what you see basically outside of us are probably 3 other sites with formal programs, maybe 4 to 5 now with formal programs, and the rest are sort of docs doing the best they can to try to string along programs. And so like in Lee County, I would say that's kind of what you see is a couple of docs who are doing their best to try to make up a program. I know we're working on trying to build out more and more in Pinellas County. Pinellas County has huge opportunity because we have Angus Jameson here on faculty, and he's of course the director of EMS, which doesn't at first quite sound like the natural place, but, you know, he's been involved really in opioid use disorder scene because he, you know, started noting the large overdose increases, especially from fentanyl, that his EMS responders were dealing with. And so that of course made him much more engaged and wanted to try to find treatment for those patients. And it's really that group, Andrew Smith and Angus Jameson, who are our faculty, have really been the ones who started to build that out over in Pinellas County now as well. But
I want to point out that every program you're describing is being created by graduates of this program.
Yeah, I was going to say
Which
that.
is the amazing part.
We are looked at by the state as the leading program in this, just so people understand that, and the state fully recognizes that. That's why we got the NIH grant, and that's why FSEP has, I think, one of the three of us come talk every time they have any type of opioid use disorder pathway panel. So we are really growing it by our graduates going out and starting those programs, and just thinking of this as like the clinical care that should happen at the programs they go to. So so go USF. I'm just gonna keep on moving through these. All right, so am I turning this over to Heather or to Adam to give us kind of the brief overview of the pathway from Adam? So you're gonna take this one still, just sort of the resident perspective overview of our existing opioid use disorder pathway?
Yeah, I can do a brief overview. So I think, we've already went over the importance of the whole pathway. And I mean, from a resident's perspective, I think it's important that we recognize that we are decreasing mortality when we do practice this. So as residents, like this should be standard of care. And so there's two brochures you'll see here. They go over essentially the rough overview of the MAP pathway. Future to be known as the MOD pathway, I believe. So what our job as residents should be in regards to this is recognition, or recognizing when a patient could benefit from this pathway, and getting them in touch with the system that's built in place for them. So when you walk into a patient's room, you should be an advocate for them, and you probably spend more time with them than the attendings do as residents. So that's the power we have as residents. And we're also being educated on the topic right now, all at once. And so if you walk into a patient's room and you think they benefit from treatment of opiate use disorder, one thing we can do is get the system rolling. We can call case management. We can get social work involved. I will call Heather. You can get Sam involved as well, or the RAs as well. And so, just at least recognizing it and being educated on the topic. So, from me, that like for a resident, that's the importance that we have, getting them involved with the system, because there's already a system built in place for these patients who can benefit from it, and why not use it? So if you guys had any additional thoughts or things to add with that.
I think that's great, Adam. And just a couple things about this brochure. So, DACO is one of our partners. ACTS is our other community partner. We have slightly different brochures for each service organization. We'll probably be working on changing these brochures around a little bit. Adam noted that the term MAT is still used here. It's funny because just a year ago, MAT was the term that was seen as not pejorative, and was the more acceptable term to use, because the prior term was opioid substitution.
Let him guess.
Sorry, I ruined it, Jack. Sorry.
Okay.
But it was opioid substitution therapy, which was this, idea that basically, well, you're just taking one bad thing and giving another bad thing. And so what's really the good of this? And so it moved to medication assisted therapy, right? To try to start to really make it clear this is a medicine, just like any other medicine, and we're medicalizing this pathway. And so that was sort of seen as the more accepted term. However, if you actually unpack that term a little bit more, then you can sort of start to see we don't really say that like Plavix and aspirin are medication assistants for managing coronary artery disease, right? We say that those are the management of coronary artery disease, right? That is how we essentially approach coronary artery disease. Insulin and other oral agents or whatever are not the assisted way to sort of add on to other things you might be doing, while you try to improve your morals to manage diabetes, right? Instead, they're the management of diabetes. And so the term is now shifted to MOUD, which is I'm working on this one, medications for opioid use disorder. And so that's where we're at right now. So I'm getting used to it too. I think we all are. So we'll have to change these brochures a bit as we go forward. And, we may be streamlining the brochure. So there's really more of an opioid brochure, polysubstance brochure, and an alcohol brochure. But right now we have them kind of done by the community providers. And so DACA sort of has one and ACTS has one. David or Desiree, do you have any comments just as about the brochure? And I know both of you have seen each other's brochure, and I'll get to the ACTS brochure in a second, or terminology or anything here about us linking. I'll get to the pathway in a second here. Actually, maybe just hold tight for a second. Let me introduce the pathway, and then I'll give you more time. This is the CAL score we talked about, and so it is on MD Calc. It is easy to calculate, but you could see that it might take a minute to do. I have done it in the room with the patient before. It's not that bad. There's a reasonable number of questions here. The RAs will calculate CAL scores for you. One thing I will say about a CAL score is it's probably not a static calculation. This should probably be a dynamic calculation, right? So CAL score pre-dose 1 of Bup, CAL score is 6. And by the way, I should mention that too. In our pathway, we're using a CAL score of greater than 5 or greater. Sometimes in the literature, you will see a more conservative approach of a CAL score of 8 or greater. And the idea of using 8 or greater is to really be conservative about not precipitating withdrawal. What we have found, though, is that usually patients have some other symptoms that just aren't revealed in the CAL score, so it's not really too hard to get it to an 8. We haven't really seen much precipitated withdrawal at a 5 or greater, and so we will engage at 5 or greater. Now, with the NIDA grant, the NIH grant, that is a CAL score of greater than 8 to enroll, so you may see some, just sort of some discussion around that CAL score to see if that patient qualifies for study or not, or if that needs to be recalculated in a few minutes. For that patient. But once you give Bup, right, we should still use an NHS score. You can't make the neurologist come do this one though. So, but you can make the RA do it. The key, I think, is though, is to recalculate the CAL score after, about 30 minutes after the Bup and make sure the patient is improving. And if they're not, you can redose the Bup. So if you give 8/2, give another 8/2. Yeah, Jack.
One thing to add about the reassessment is give yourself time, like make sure it's a good solid 30 minutes after the first administration, because occasionally you'll see this phenomenon where a patient will take the Bup and in the first 10 to 15 minutes actually have increased withdrawal. They may freak out a little bit and then it will go down. I'm not exactly sure why that happens, but I've seen that a few times. If you reassess too shortly afterwards, either the drug's not on board or they're going through that little initial uptick. I don't know how to explain that, but I've seen it a few times. Just give them a good 30 minutes.
So Adam, where's your patient at during all this?
Yeah, so recap, she's the 40-year-old female who's currently having a manic episode that is complicated by heroin withdrawal in the setting of recent heroin use. And she's here requesting help. So my calculated CAL score, although dynamic, I think at worst it was a 27. And as MD Calc defines it as moderately severe withdrawal. And so I kind of opened this up. Do you want to give this patient buprenorphine?
Throw in the chat, you guys. Is it time to give this patient some Bup?
Everyone that agrees, enter yes or why.
Right, so remember, this is our patient who's tachycardic, hypertensive, pacing the room, requiring a lot of redirection.
Okay, the votes are coming in.
Here we go. When was last use? Okay.
6 hours ago.
Oh, and what was it? Anyone remember? It was heroin, right?
Mm-hmm.
Yep.
So what do we think about that? So we got some confusion here, right? Because we said 12 hours earlier, but now we've got a patient who's clearly withdrawing, has a high withdrawal score. Any medical guidance here as to whether or not we could induce this patient still, even though we're not at the 12-hour mark yet after a heroin use at 6 hours in a withdrawing patient?
So one consideration is that what's marketed as heroin is not necessarily diacetyl morphine. Frequently it's adulterated, and sometimes it's a complete substitution, like it's just straight up fentanyl. So she may have just been injecting straight up fentanyl.
So Dr. Conquest says she would just base off the CAL score, and I think probably the clinical picture, and probably rely less on the timeline of when the last use was. How do you feel about that? I personally feel just like Dr. Okonkwo. I would treat this patient at this point. So 12 hours is a rough guide. It helps us guide to when we could expect certain CAL scores. So it's an approximation for when we might want to see a high CAL score. It doesn't mean that if you have a high CAL score at less time and a clinical picture that you can't treat the patient. So do any of the faculty or anybody who providers disagree that they would probably start considering giving this patient some bupe at this point? Great. So I think most people,
you probably would. Yeah.
Okay. Any other thoughts around, like any thoughts about why you would or wouldn't? That's great, David. Thank you.
Now, what if the patient was febrile and has a new heart murmur, and you're concerned that she's got sepsis? How would that change it?
In other words, I think the question you're getting at, right, is patient is going to get medically managed, but does that preclude them from getting bupe?
But also, is there a complicating diagnosis that is influencing the cows? Because cows does rely on some findings that are not exclusive to opioid use disorder, like tachycardia. So you always have to consider that. And sometimes
our peer specialist points out that this patient's about to leave AMA, I think, at this point, if we don't treat them. So I don't know if there's a specifically right answer here. It's kind of like AFib in sepsis or anything else, that appears in sepsis, but it's really due to sepsis. I think you got a patient you need to manage for sepsis who probably is also withdrawing, and that CAL score of 27 may come down to 6 or 7 or 10, but it's probably not going to come down to 0 or 2. So, even if this patient's sick, I think the benefit of treating this patient, with both buprenorphine and the medical indications for treating the patient with endocarditis at this point are probably worth doing in parallel, I would say.
And I want to add that this is a good illustration of a general principle that comes up a lot. Emergency medicine is different. So while we have all this literature on how to use bupe in the outpatient setting, that's not the same as what we're doing here, right? Who talks about a patient presenting to the outpatient Suboxone clinic with endocarditis? Like that's not even.
Although I'm sure our colleagues have seen that from the community setting.
Oh yeah, I'm not saying it doesn't happen,
but it's not ideal, right?
Like we have slightly different priorities and slightly different goals. So that's why it's so important that we, be trained in how to do this so we can make it our own.
Yeah, so this patient, their picture was a little clouded as well. It wasn't just heroin withdrawal. It was also this manic episode. She wasn't sleeping for 3 days, well-known history of bipolar. And I think our decision-making was a little clouded from that. And we weren't sure which way to go in regards to treating her. Like, do we just go with opiates? Do we do opiates and bupe or just bupe? But ultimately, I think Dr. Pleasant initially nailed it. She said, does the patient want treatment? And this patient, I'll get more into it, but she wanted help, but didn't want buprenorphine. And this may have been a failure on my part to further go into what buprenorphine is for her. She had Suboxone in the past and she didn't have a good experience with it. But, I think if given the right context and if my education at that time with buprenorphine had been up to par, I think we could have not convinced her, but at least educated her better on buprenorphine, and could have encouraged her to be more interested in receiving it. But she did want help. She wanted to go to a treatment center, just not receiving medication. But we'll get more into it. We'll get more into what happened with her later, actually. So these are all things that should come into account when you are considering treating a patient with bupe.
Yeah, and I don't know if now's the time or not, but if maybe David or Desiree even want to weigh in on this. Some patients do tell us that they've tried bupe in the past, but had a really bad experience with it. Any thoughts about how to approach those patients, or thoughts about how to talk around bad experiences? Heather mentioned maybe they say they have an allergy, but maybe they actually precipitate withdrawal. Any?
So they do. We have had patients that come in and, I mean, they'll say it about all different types of medications, not even MAT in specifically MAT, because of maybe a bad side effect or an experience that they associated with the medication that wasn't truly clinically associated with the medication. Our providers do a real good job of talking with the patient on why they think which medication is best. And sometimes it is that one that they come up with and say that they've had some kind of negative interaction. And sometimes the patients will be totally against the going with the medication, but on the other side, sometimes they'll try it. And our providers do a real good job talking them through that process and then setting up additional appointments to see them and just to monitor if that interaction is occurring again.
So when we do get the complaint on, and usually it's not buprenorphine per se, but the Suboxone, we'll try Subutex, and many folks who for some reason don't tolerate the Suboxone will tolerate the Subutex, and of course if that doesn't work for them either, they still have complaints, then we'll suggest that they look at naltrexone, and we'll try to move them over to that.
Great, thanks. That's great. So John is asking about the precipitated withdrawal. How do we treat that? Again, just make sure you've adequately actually given, just kind of like the kids who come with fevers, on the peds side, and you ask them how much Tylenol they got, and they got, underdosed on Tylenol suspension, right? So you first maximize their treatment. So make sure you maximize their buprenorphine. So again, probably for our pathways, we're building out up to 32 milligrams is reasonable. And then you can start to add on those adjuncts like Jack talked about. Okay.
Bring that
so
up. I had a patient who came in, it was probably about 2 years ago, around the time we were getting some of this built up. He came in from another facility, whether it be another hospital or one of the outpatient facilities, saying, I went in, I got either buprenorphine or Suboxone. He wasn't sure. I told them I hadn't used and was withdrawing. They gave me these medications, but I'd shot up with heroin on the way to the facility. So he came to me 45 minutes after leaving their facility in floored withdrawal, saying, I'm dying. I identified it. I think I ended up giving him Clonidine. It was a couple of years ago, I don't remember, but I was wondering what I should have done from that point.
Yeah, I've seen that before as well. A patient who accidentally got dosed buprenorphine instead of methadone. I'm not sure how that happens, but it did. And in those cases, like I said, basically the killer key is in your opioid lock. You're not going to be able to manipulate that. You're going to have to address it through another pathway. And so I'm definitely a fan of Clonidine, but also gabapentin too. And don't be stingy. Like it takes a relatively stout dose, but you're not going to kill anybody with 600 milligrams of gabapentin. And then just tailor it according to their symptoms. If they're puking a lot, Zofran, Haldol. If they have muscle aches, acetaminophen, Toradol. Fluids, because fluids fix everything. And just reassure them that they will feel better. It's not going to last forever, and they're going to get better with time.
I think it's important too for people who are maybe giving bupe for the first time or getting comfortable giving this in the ER. We've only precipitated withdrawal now in hundreds of patients two times. So it's not super common in our pathway. What if we have this patient who, let's go back to that first patient that we talked about in those sets of patients who was who admitted to IV drug use, had come back to the ER now with the second abscess, but looks really stable. Opioid withdrawal scores 0, 1, whatever, too low to give meds to. Do we just let them sit around the ER for hours and hours and watch them withdraw and then start to induce them? What do we do here? We're building out this pathway, and I'm gonna let Jack talk about this pathway for a few minutes as well.
Yeah, So this is the home induction pathway. And I will say that, like, while it seems radical to us, this is probably the most common way that patients are treated in the outpatient setting. Like, for instance, if a primary care doctor were to prescribe buprenorphine, they typically don't induce them in clinic because there's a lot of legislation and regulation that goes into how you have to store those meds in your clinic. And a lot of docs just don't want to deal with that. So they do home induction. It's safe. It's well established as safe. And hopefully we'll have it up and running soon.
Yeah,
like
we're not
Brian
quite
said.
live with the home induction pathway,
Yeah.
but a couple things around it. We would definitely want to still involve all the pieces of the MAT and
Yes.
the MOUD enrollment pathways. They would still be enrolled. We would still want to get them follow-up visit arranged with one of our, DACA or ACTS providers. So they would be locked into that system. Samantha and the team would be aware of this patient. They would conduct a follow-up, phone call with the patient. So we're still building out some of the intricacies of this, but this is sort of the next phase that we're heading into. David, Desiree, are you guys seeing patients? Is this a thing that you guys do or see? And Brian, I would ask you too, is the OBOT clinic doing any of this as well?
So we're not doing any initial home induction. They are induced here, and most of our clients, they get induced in detox, and then transition to our medication, which I prefer to call medication-assisted recovery program. But we don't just give folks generally. There's been a couple of exceptions. Give folks a script and instructions about how to do this at home without coming in here first. I don't know, Desiree, do you guys?
No, what we do is we induce on the day of intake. But we have received individuals from the ED pathway program that were given a bridge dose. And it really was very helpful because that individual wasn't yet ready to come into the facility to start treatment. So it gave them a couple days to get their manners in order to be able to come in and be ready for treatment. But we induce on the day of intake.
And as an aside, that is standard practice moving forward for our program, that all patients are going to be prescribed 3 days worth, regardless of what day they present, exactly for that reason.
Yeah, and I'll spend a little time on that too in a second. Brian, does OBOT clinic ever do this?
We only do home induction.
Only do home induction.
We only do home induction. Yeah, I mean, there's a lot of issues for OBOTs with having medication on site. The other option for some patients is if this is the first time they're doing an induction, they can bring their prescription to the clinic, but oftentimes patients have either tried Suboxone before, buprenorphine, and kind of have a sense of how to do it. We also provide counseling on what to expect. We know there's a lot of good data showing that home induction is effective and also safe. There's a question of, can you explain OBOT? And yeah, so OBOT is called office-based opioid treatment. It's essentially treating addiction in the primary care setting. So we have three physicians who have DEA or they have their Data 2000 waivers, and they essentially provide buprenorphine in the primary care setting. So we have some patients who see us specifically for addiction, right? And we also have patients who have been discharged after an admission for serious bacterial infection, be it, abscess, endocarditis. And it works really nicely to be able to co-manage both their addiction as well as some of their medical issues. We use kind of like a treatment stability index for how soon after induction we see a patient. Generally, if a patient is having any issues with induction and stabilization, we'll see them within the same week. Otherwise, we'll start to space out their visits from a few days to a week to even 2 weeks up to 4 weeks, particularly our patients who are very stable on their regimens.
Thanks for that, Bryant. Okay, I'm just going to keep on moving forward. There's still some more opportunities to talk about the pathway here in a moment. And so what Jack just said is very important. We are shifting to induction versus prescription. You know, for us, it was a big lift to go from 0 to something. That's always the biggest lift. We had never really given bupe in the ED before. We had never really treated with bupe before. And so for us to start doing that, what we first did was we took advantage of really a loophole in the law that said that you could give buprenorphine in an acute setting without a data X waiver, but you couldn't prescribe it. And so that's what we started doing to build this program. We give the bridging dose. As we move forward, clearly the clinical best practice is to prescribe a 3-day course of buprenorphine. We've got a great warm handoff process, you know, with ACTS and DACO that is working very well. But of course, there's nights, there's weekends, things happen, and we want to make sure that patients get a prescription for buprenorphine. Now, the problem, of course, is you have to have a data X waiver to prescribe. First of all, I want to go back to where are we at with best practices. So AAM has issued this statement basically that really, unless there's some other reason why you can't, you know, give the medication as a prescription, the goal would be to first try to prescribe. And that's a D'Onofrio-based sort of white paper that came out from AAM recently. So we're going to be moving to prescribing versus just inducing. Now, of course, you have to have a prescriber available to do that. So what's been very cool is that the number of prescribers we've had has gone up from 1 about 2 years ago or so to this list that you see here. The ones on the left actually have DEA waiver in hand and it's updated and they can prescribe today. And then the ones on the right here, actually Dr. Zachariah and Dr. Okonkwo are fully waivered. Dr. Okonkwo, we just checked the SAMHSA site, and both Zachariah and Okonkwo are both fully waivered, but just waiting for their DEA actual certificates, which we'll need to just update pharmacy, I think. But they do have waivers already. And Simmons should also probably have a waiver in hand. And Dr. Thomas, I know, is going through the process. So you have a number of providers now that are waivered. What Heather and Samantha are working on is creating essentially a schedule of who is the waivered physician that is on at the time. Ideally, we would have somebody, you know, just in the ED anyway, that could be the waiver physician who would write the script. However, if we don't have a waiver physician in-house, what we'll actually be doing is moving to a model where this group of people will be taking some call if there's nobody actually in-house, and we'll be playing a little bit more telemedicine again as well, which we're actually experimenting with right now as an ED-based concept through our 30th Street clinic. I'll talk about that some other day, but we'll basically use that to prescribe bupe in conjunction with the RAs. So this is going to get a lot easier for us to be able to prescribe bupe from the ED. And Jack's right, in a perfect world, you know, I know we'll eventually get to a place where we just either the waiver goes away and isn't a thing anymore, which is actually the perfect world if there is no waiver. But while and it becomes part of training just to know medicine like this. But eventually we'll get to a point where everybody will have a waiver. But this is a big step forward, and you can just do the math in your head by probability. Almost always one of these people will probably be in the ER working. And so we'll have access to that. So a big change, I think, recently. Again, just some more supportive data. The point here is that we've actually seen declines in not just, or improvements in engagement and care, but also declines in mortality for people on bupe versus nothing. And now I do want to turn this over to Heather and to Desiree and to David for a few minutes. Heather, maybe you could just sort of talk through the pathway, maybe take about 5 minutes because we are getting short on time. And then I would like both Desiree and David just to talk about any, their site, their program, and what they do at their individual institutions. So Heather, I'll hand it over to you.
Great, thank you. So I'm sure many of you are familiar with this clinical protocol for our substance use disorder pathway. So when a patient presents, first we assess if they're acutely overdosed, and if they are they Marchman eligible? And soon this will also have a box for home induction once we get that up and running. If they're not, are they MAT eligible, right? And so a couple of things need to happen. If they're not eligible, they may be a pain management patient. And if they are, do they need a referral to their PCP or pain management? And then Also, we utilize Dr. Shuey's and Dr. Oxner's OBOT clinic for these patients as well. Does the patient also have active substance use for benzodiazepines and would need a taper to come off of those benzodiazepines? We would refer to ACTS to have a medical taper for that. Is the patient a legal hold? Social work would provide resources, and we're also working on shoring up more of a solidified pathway for legal holds that gives them that bridge to care in jail as well. So if none of these things are true and the patient is open to treatment, a member of the team will come do a COWS score and meet with the care team and go over their findings. There will be an induction with buprenorphine, and you can titrate that up to 32 milligrams like we discussed. If the patient becomes admitted for any reason, just place a non-emergent consult for social work and psychiatry to continue following that patient for continuation of care for buprenorphine. And then we do a warm handoff referral to DACO or ACTS. And I think this is a great place to have Desiree and David come in and talk about what that warm handoff looks like.
David, do you want me to go
Desiree,
first? Okay. All right. So this is how it happens with us is once, sometimes we do consults prior to the patient even being referred over to the agency to determine if they're appropriate for a level of care, which could be anywhere from our intervention services, MAT, medication assisted treatment, or could be all the way up to residential level of care or co-enrolled in a couple of those levels of care. So we do a consult, and then once the consult appears that the person is appropriate, the referral is then sent over. Once that referral is sent over, one of our peers is engaging with that patient or that patient's contact, next of kin maybe, or spouse, and to try to engage them to get them to come into treatment. So a lot of times the patients will have questions because, you know, they were in acute crisis when they were in the ED. They maybe didn't understand some of the information that they were told. So a lot of times we're just repeating, you know, what time we do intakes and what's going to happen when they get on the floor. Once they come in, one of our peers meets them at the front door. So that really helps because sometimes there's a lot of anxiety about coming into treatment and an unknown about what's going to happen that day. The peer will stay with that patient throughout the whole intake process and be almost that patient navigator person to get them through their first day. They also introduce them to the treatment program, show them around even physically to where they would be coming in the next day, really to make it comfortable for them. And then they also meet with them within a week to see if they have any questions or how treatment is going. Our peers also stay with the patient throughout treatment and, you know, do collaborations with the assigned counselor as well. So our patients sometimes will come in just for MAT services, but then figure out that maybe they need a higher level of care and will be referred to outpatient services or residential services.
And I do want to say one of the really cool and innovative things that DACO has done for all patients that we send to them is they all have the same counselor for continuity of care. So that has been really, really helpful too.
Mm-hmm.
So at ACTS, our process is a little bit different in that most of the patients who come from Tampa General come into our detox facility. They've been assessed at the hospital, and in most instances, I think we've had a couple of MD marchments, but in most instances, they come voluntarily, you know, to complete their detoxification. And it can be either for opiate use disorder, alcohol use disorder, or polysubstance. In most instances, we're finding, you know, most of our folks, if we do a 14 panel, we'll generally pop on 6 or 8 of those panels. It's like they're trying to set some kind of record or something. And of course, what we're finding a lot of now is people that are using stimulants. Many of the methamphetamine and the amphetamines have fentanyl mixed in with them for a whole variety of reasons. And so when they come into detox, if they are on the, if they are opiate use disorder, then we induce them with Suboxone. They have to wait 24 hours and have a, or have a CAL score of 8 or greater to go back to what was talked about earlier. And our purpose for doing that is both to, we know that, well, because it's, it's best practice, but we're also trying, to introduce people to medication-assisted recovery. We know that when people leave us, if they are not on medication-assisted recovery, their chances of relapse are 90%. And also Suboxone reduces the chances of overdose by 50%. So, so we're very anxious to get them into that. While they're in detox, we have our peers continue to work with them, and we look at care coordination. We do have an outpatient detox program that they can transition into, or outpatient. And then, of course, as we've already discussed, our medication-assisted treatment program. And that program will serve them, will provide free Suboxone for upwards to a year or longer, depending upon their needs.
And Maureen Decker just pointed out that for this pathway, we should always get social work and case management involved. And what's really great at our site, of course, is that we have that resource 24 hours a day. But definitely something we always want to do is get our case management social work team involved, which I think happens often, but we could always improve as well. It does help us with just making sure these linkages happen smoothly, and it takes a lot of the work off the plate, clinically for the physicians too.
Jason, could I just interject
please,
too?
Please.
So Samantha Reale is on our ACT staff, and she is deployed there to Tampa General, is on the unit and facilitates those referrals. She really was a gift to us from Tampa General. So we, and now she really works in partnership with us. And not only does she make sure that there's a warm handoff, but then she follows up and makes sure that the person gets here and will follow up with people who don't make it for some reason. So that's a huge, I think, a huge part of this process, which really makes it effective.
Absolutely. The peer specialist has changed the ballgame. Desiree, did you want to add something too, it looks like?
I did. I just wanted to piggyback on David's. We agree. He's absolutely right with the peer involvement. Even the peers that are offsite and maybe not at the hospital it's super important to engage with these patients. At first, when we started the program, we were tracking the patients for 30 days after their referral date, but now we are tracking them on the back end, 60 days, 90 days. It just depends on what the patient is saying when we're reaching out to them. So we just don't let any patient just go. If there's some sliver of hope that they're going to come into treatment, we're still calling them back and trying to get them into treatment.
That's great. And is there anything else either of you want to say about your institutions? We're going to come up on time in about 15 minutes or so. And I want to make sure I give space if there's anything else you want to say about your institutions. And what I think I'm going to do is save alcohol and other substances for a later, if you guys will both come back for a later talk, because I know there's some other stuff with opioids we want to cover here. So I just want to make sure I give you an opportunity to say anything else you want to say about ACTS or DACO.
Just one other comment. I mean, we work very, very closely with DACO and each of us refer to the other. Our peers, even though they might be employed by ACTS or DACO, are really, our focus is really on what the patient wants, because we know that patient taking responsibility and the patient driving their recovery is key to all long-term success. And so, it doesn't matter to me, whether a patient comes here or goes to DACO. What matters most is that the patient get help.
The only thing I would like to add is, we're extremely grateful to work on this project with you. It has really opened our eyes up in a different way and given a lot of people opportunities to succeed and to begin their work and their long-term recovery. We've seen the personal stories, which may not have been initiated if they didn't end up in the ED. So I just want to say thank you, because one of my professional goals is to break down some of these silos that have been set up in the community when we're all working for the same purpose, for the same patient. We should be collaborating. So thank you.
Great, thanks, Desiree. I'm going to keep on moving because there's a couple more things I want to cover, and then we're going to, when we get to the near the end, I'm going to let our faculty have any questions or say anything, and also I want to make sure to share a couple of really good stories as well. Just to give people a quick update, the last 2 years, this program's been going for about 2 years now, building on the fly, essentially. Screened over almost 800 patients, enrolled, hundreds of patients now, 241 into the MOUD pathway. And our success rates, look just like the Dino Frio paper in JAMA, about 70-something% engaged. Jack pointed that out yesterday. It was a great thing to point out. And it's good for Heather to remember for paper writing too, that our success rates look the same as Dino Frio. So we're really happy with, as we all know on this Zoom, a fairly difficult population to keep engaged in care, this percent that we've engaged in care. So I think everybody's doing an excellent job. The other thing, this started funding-wise for us in the ED and for Heather's position through my work with HIV and hepatitis C. I was able to make the case to the people who fund me for hepatitis C work that you can't deal with hepatitis C without dealing with opioid use disorder. It doesn't make any sense. And so for about 3 years, I was supposed to, link people with hepatitis C to treatment. And, I realized that all the people under the age of 60 who had hepatitis C were all young people who were using opioids. And so we started moving into really considering how these two diseases mingle and how treatment needs to be co-located. As a matter of fact, we're getting very close to launching a pilot project at DACO through Tampa Family Health Center, where patients will actually be managed for both their hepatitis C disease and their opioid use disorder at the same time. Essentially, once they get a little stabilized in opioid use disorder, and we'll do a whole nother lecture on hepatitis C at some point, but just so people know, we're thinking about how we co-locate those services. I know Bryant Shuey is doing the same thing at the OBOT clinic as well. A lot of our patients have polysubstance use. A lot of them use heroin. Dilaudid is another common one. I'm just going to keep on moving. I think I've given some time for DACO and ACTS and OBOT to talk. I guess I didn't ask Brian. Brian, is there anything you want to add if you're still on the call about OBOT that we didn't touch on?
I think he had to go.
Got it. So I know he put some things in the chat about OBOT. And this is the referral information for the OBOT. The idea of OBOT, of course, is that these are medically complex patients. For some reason, they probably aren't going to fly quite as easily at DACO or ACTS. They probably have an acute, they have COVID at the same time. They have some acute ongoing medical condition that maybe makes them a little cleaner, or maybe get admitted, to the hospital. They're a USF medical patient anyway, like a primary care patient for USF medicine. So those are the patients we're trying to build out for the OBOT clinic to potentially take care of. Pregnant patients. So we do have a pathway for pregnant patients. Someone mentioned earlier that Subutex is the preferred medication. That's without the naloxone. So we do have that available in the ED for these patients. They can still be induced. And Heather, do you want to say anything about this pathway that we have for our pregnant women?
Yeah, really quickly, I just want to say that we do have a dedicated process for pregnant women, and we want to identify all of them and loop them into treatment. I think it's really critical. And best practice is to start them on MOUD. We do start them on Subutex, and then DACO has a really robust program for pregnant women where they're able to stay in treatment during the pregnancy, and then they can actually live on site after the birth, so they can be with their child while they're still receiving treatment.
Great. And then Tiffany Pleasant knew where we were going next and wants to know what to do with the patients who are under 18. So first of all, I think it's important to note that we are able to engage those patients in care, that there's no legal reasons why we can't, have those patients make decisions on their own about that care. we've become great partners with Ybor Youth Clinic through our HIV work and hepatitis C work and some other programs we've launched. Ybor Youth Clinic is a joint effort between USF Health and some other organizations. Closely works with Metro as well, which is a health treatment site that sees a lot of the LGBTQ community. So Ybor Youth Clinic's been great. Diane Straub and Claudia Espinosa spent a lot of time at Ybor Youth Clinic. That's where we would send patients who are under 18 with opioid use disorder. Jack, do you want to say anything about drugs like Bupe and stuff in this patient population? 13, 14-year-olds and Bupe?
Yeah, so as far as I understand, and this may have changed, but as far as I understand, there's still no listed indication for pediatric patients, but that's not unusual, right? Most of the drugs we give them don't have a specific FDA pediatric indication. That said, for a patient who is more or less physiologically an adult, like a adolescent, like somewhere from the age of like 13 to 17, you can pretty much treat them as you would an adult. There is,
so I think that's the key. There's no absolute contraindication, not clinically studied. I don't know if our community partners have anything to add on this, but there's, physiologically, they're like an adult. And we do have Alex Farish now, one of our pediatric emergency medicine physicians, does have some experience in this work, and it's actually data waivered as well. And so she can sort of help us build this pathway out. So still building some of the pathway out, but we do have a pathway for people under the age of 18. One of the things I think we're struggling a little bit with right now, which we're still trying to build out, but we're getting closer and closer to a build out, is what to do with our patients in custody of law enforcement, especially under recent custody, who we know are going to withdraw. I'm actually the representative of a developing criminology center at USF that's run by Brianna Fox, who's pictured here. We're starting to work on this to figure out how we build out these sort of jail pathways. I don't know if Axe or DAC have any comments on that, but one of the struggles we do have sometimes is patient under recent incarceration who comes in, says, I use high amounts of drug, I'm now going to go into incarceration and likely withdrawal.
We do. We actually have a certain number of patients right now that are incarcerated that we are providing medication-assisted treatment for while we're there, because we know that, upon discharge of jail or incarceration, they're at a really, really high risk of overdosing and harming themselves. So we have partnered with the jail to be able to dose while they are in jail.
Great.
And we're doing the same, but we just focus on the Vivitrol side because DACL's taking care of the Suboxone.
That's great. So I think Heather and us will probably work with you guys a little bit more too to figure out how we can build this out, from the ED side to make sure those patients get linked to the right place, while incarcerated. Okay, we're gonna, if it's okay with everybody, we're gonna save alcohol. David and Desiree, I would love it if you guys would come back in a month or so and do polysubstance and alcohol with us, if that would be okay. We'd love you to come back. I know Dr. Gillen has told us we have some more time for that. I think I'd rather give the space to that, I think, that it needs. Would you guys be willing to come back? Sorry to put you on the spot.
Yes.
Great, thank you.
Yes.
So for the residents to know, we do have a building alcohol pathway. We'll come back and we'll really give it the same space it deserves, just like we've done with opioid pathway here. We'll come back to this as well in November and really spend some time with alcohol and polysubstance. Some patients are not ready to start buprenorphine or really engage in any of these conversations about going to Axe or DACO, or really want to hear much of what we have to say. So there's sort of a saying in this field of meeting a patient where they're at. And that, I think, is also our responsibility. So Aaron Wall, who's actually one of the board members for FSEP, developed a lot of what you're seeing right here for harm reduction handouts and pathways. And so, our job is to keep the patient from getting sicker. And so sometimes that may be some counterintuitive advice, like telling patients how to get clean needles or how to clean material that they're going to use to inject. And so this is a harm reduction handout that we use. We're gonna change this harm reduction handout because now we actually have a formally funded harm reduction project, which exists in the syringe services program. I'm going to spend like 2 minutes on here in a second, but just understand that you're going to meet patients at different places in the pathway. Dr. Gillen showed that curve of where patients might be in their addiction process. And so if we meet them here, it would certainly be great to take a 20-year-old who is using every day but does not have hepatitis C or HIV yet. It'd be great to keep them that way for when they're ready to engage in care. We're not also co-managing HIV or hepatitis, right? We're just trying to get them off of opioids. So we want to do our best around that. We'll talk about chronic pain more in November. I do want to make sure I mention we do have the free Narcan program. Thank you to DACO and ACTS for helping with that program, where we do supply our patients with Narcan. So any patient we're enrolling in the MAP pathway should go home with Narcan. They can get that Narcan in the ED satellite pharmacy. There's at least a couple of doses there in the ED satellite pharmacy. If not, they can go to the outpatient pharmacy and get it. It is free for the patient. And so they need to go home with that. Any patient that comes in with any type of overdose complaint, any patient that comes in and is going into the MAP pathway, any patient you have concerns about, you should, and I'm not going to touch the legal parts of the Florida law about prescribing Narcan. I'm just talking about for this population, those patients should be getting Narcan. Now, when we give Narcan, our research assistants are actually going to go over rescue breathing with those patients and then teach them rescue breathing techniques. And they're going to get this handout as well, which is when to utilize Narcan. So, right, it doesn't do any good to give somebody Narcan and not tell them what to do with it. So we do have some teaching that we do for Narcan. And the new program we've just started that we got the idea from Norwegian or Switzerland-based model was to start including postcards with postage paid for every Narcan that we give out. And we ask the patients to please just send it back to us if they use the Narcan so we can get that information back for just, our own reporting purposes and understanding of what's going on in the community. Zach Twilliger had if you want to reach out to him, he had one of our former residents had a life-changing experience in the ED when a patient came in and told him that he had used the Narcan we gave him, or the girlfriend had said she had used the Narcan that we gave them to save the patient's life. And it really changed his whole perspective, I think, on some of this clinical care. So we have that program. Unfortunately, I'm not going to get to talk about the NIDA grant too much, but just to make sure everybody understands, so I have an NIH grant, it's an NIDA grant. Heather and Jack are both principal investigators on the grant. Dr. Okonkwo, Dr. Simmons, Dr. Zachariah, Dr. Ween, Dr. Arnold, Dr. Smith, they're all sub-investigators. Dr. Thomas is working on it. Dr. Simmons is a sub-investigator. So they're all investigators on this trial. Basically in the trial, we're just gonna be doing either a randomized controlled trial, standard pathway that we already have. The new piece, this is for David and Desiree too, because I don't know how much education we've done around this for you guys yet. The new piece in this will be one group, half of them will get injectable, and that will give them 7 days to, have a half-life of that injectable. So follow-up could take a little, they'd have a little longer for follow-up if needed. We'll just kind of keep on from our end, working them through the standard process though, and normal pathway. The only difference will be getting that oral dose versus the injectable. Elizabeth Ballance is the research coordinator on this, and we'll get some more information out, but this is going live this week. So you're going to see a lot more emphasis from the research assistants of enrolling and randomizing the patients. This should not change anything about DACO and ACTS follow-ups. Both patient groups would still follow up at DACO and ACTS, but would also just be going under some research follow-ups too. And if we need to get more information to Heather, to Desiree and David, Heather will work on that.
Yeah, and the sooner
ahead,
the sooner you can identify a potential patient, the sooner we can get them screened and consented if necessary, and the sooner they can get the treatment.
Yeah.
So just keep your eyes open.
And so peds will still go standard pathway. Pregnant women will still go standard pathway. They're excluded from the trial. So these will be kind of just adults who could go into the pathway and get randomized to meet inclusion criteria. Jack, are you going to say something else about this?
Oh, I was just going to say that, if you got a patient that like really really needs treatment, I mean, don't delay because due to the research project, but do keep it in mind that prior to like writing that dose for the Suboxone, just run it by the RA and see if the patient actually would be a candidate.
Yeah, they'll be screening really actively. And I would say, you know, most of our clinical trials, we've built enough infrastructure where we very rarely would delay clinical practice. And so if that's an issue where you think we're delaying clinical practice by enrollment in the trial, then that's just something you need to come back to Elizabeth and me and talk about. But ideally, you know, every patient that we're screening for MAT or MOUD is screened for the clinical trial as well. And so that'll start this week. Elizabeth, sorry to put you on the spot. Do we have a formal go live date for the trial yet?
We're actually live right now. I'm screening from the ED. I screened yesterday, and I'll be screening all day tomorrow, the next day.
Sweet. So there you go. So we will, that will be the change that happens now, that will now be randomizing these patients if they meet inclusion criteria. And if they don't meet inclusion criteria, they're just going to stay in our pathway. Jack?
And Elizabeth, could you tell everybody what the screening hours are going to be?
Well, anytime, once all of our RAs have all their training completed, anytime there's an RA there, they'll be able to screen for this study. The screening hours are just limited around my schedule at the moment.
Yeah, so I think for the clinical providers, just think about screening hours being 24 hours a day, and then on the back end, we'll kind of work out whether or not we can actually put them in trial at that time. Okay, but for the purposes of being the ED, you're going to screen them. The RA is going to either be there and be involved, or Samantha or Heather or myself or Jack will get involved. And if we're not able to enroll them clinically in the trial because of an off hour, then we'll put them in the standard pathway. But as we're moving forward, we're getting closer and closer to 24-hour coverage by our RAs, and then it just takes some time for them to all get. For those of you who've done the training, it's extensive. I know the faculty, a lot of them have done the training. It's a long, extensive amount of training. So it just takes, the RAs have to do also that training. So it just takes a little while to get them up and running. So that is live. Great. I'm just going to keep on moving. I
Dr.
mentioned
Wilson,
yes, Elizabeth, thanks.
One thing I'd like to note is that the patients cannot be admitted. So we're going to have to find those special patients that need this but can't be admitted.
Which is actually Heather, a lot of them.
Yeah, as I was going to say, I think the vast majority of the 180 or whatever that are still in treatment were discharged. So it's the common thing is they get discharged in the ED. I don't know if you have numbers for that, Heather, what the admit versus discharge rate is for our MAT enrollments.
Admissions have been higher recently. I think that's why I listed that.
Got it. Historically, they have not. Historically, most have been able to go home from the ED. So I don't know if that's just something that's changed because of lack of RAs being there to kind of engage in the pathway, or what.
Clinically ill patients, endocarditis, cellulitis.
Got it. Okay, but from our purposes as physicians, we're still going to screen them, and they'll just go into standard pathway if they don't meet the randomization criteria. Anything else you want to add, Elizabeth, while you're on?
No, that's all.
Okay, thanks for that, and thanks for joining. I talked about the pilot project with hepatitis C. I do want to mention this very quickly. So we're one of the 2 sites in the entire state of Florida that now are going to be running a syringe services program. So these were illegal in the state of Florida up until about 3 years ago. Miami got a pilot sort of project allowed by the state legislature. It had to be in the county of Miami. They had extraordinary success. And what really changed the ballgame in terms of the way this was viewed was they identified an HIV outbreak very quickly by doing HIV testing with syringe service exchange. And so that kind of led the state to say, you know what, there may be some benefit of these programs. And so let's leave it up to the counties to decide if they want to have these programs or not. And so once it was left to the county, we began working very closely to advocate for this type of program. Me and Department of Health and Jack and Heather and Brian Shuey worked really hard and Asa Oxner worked really hard to get this type of a program passed by the Board of County Commissions, which it passed one vote against, I think, in February of 2020, just before the epidemic. I was able to secure funding as well for the program from the IDEA organization, which is the organization that's in Miami, running at University of Miami. So we were finishing up some contracting pieces with the county. We're looking at a go live date of probably in December. And this will be a joint effort between us and USF. USF runs a Tampa-based street medicine program. It's a mobile unit that already has established relationships with a lot of these patients on the streets. It goes to 3 different sites a week. We're going to be staffing our focus team member, a new focus team member on the mobile unit. They'll be doing the syringe services, syringe exchanges, also HIV and hepatitis C testing. We'll see a lot of linkages here between our ED-based population. Dave Ween's even exploring looking at some research-based projects out here, like soft tissue skin infection, 1-dose IV antibiotics on the street medicine mobile unit. So I think this could be a really exciting project. So we now officially are Idea Exchange Tampa. So Hansel Tukes and his group in Miami ran the first syringe exchange program, their Idea Exchange Miami, and we are officially branded as Idea Exchange Tampa. Contracts held by Tampa General with Board of County Commissioners with the USF subcontract. So it's got all the right players. The way the legal part of this worked is the Board of County Commissioners had to okay it. And then the Department of Health had to say, yes, we want this to happen, but couldn't fund it. So you've got all the right stakeholders there. And I was going to say one more. Oh, the one piece we're still just working through right now through the criminology part of things and our work that, and Ryan's bringing this up right now, involvement in advocacy. Well, Dave Orban and Heather have been involved in the behavioral health task force. I sit on the healthcare advisory board for the county. So we've been actively involved in making sure that our law enforcement colleagues and representatives don't just turn around and arrest these patients that are coming to our units. So we're working on that right now with our community liaisons as well. So yeah, that involvement outside of the ED is critical to make programs like this work. And we're almost there, Jim. So I'll give you back your time in just a second. So I talked about this, the HIV outbreak that was stopped from doing this syringe exchange in Miami. This is Miami's, I'm sorry, this is our version. This is the street medicine mobile unit. So this will go around to 3 different sites a week. We'll do anonymous and confidential HIV testing on this, do the syringe exchange there, hand out naloxone. This is the naloxone postcard up in the top. This will be given out with every naloxone script that we give out now, and can be sent back by the patient, postage paid if it's used, so we can have record that that naloxone was used out in the community somewhere. I'll skip some of the cool stuff going in the future, but I will say, you think we're cutting edge? Mount Sinai in New York is actually putting Bupe on EMS rigs, Andrew Thomas, and they're actually administering Bupe with naloxone at the same time, really pushing the envelope, trying to keep out that quick, withdrawal that patients get from naloxone, and seeing if they can get more engagement at time of encounter for sustained downstream treatment. So that's some new work that's going on, which is pretty cool. I do want to spend just a couple minutes, Jim, just on some of the cool success stories that we've had. So I'm going to turn it back over to Heather to talk about those, and I'll just wrap up with any questions right after that.
Great, thank you. So I have 2 really cool provider success stories, and then I'll hand it off to Desiree to give a couple of downstream success stories. So our first one is a submission from Dr. McKenna, who said his most memorable encounter was a young man who came to the ED because he was in withdrawal and wanting help, and he heard that TGH was respectful and treated people like him kindly, and that he'd always avoided doctors and hospitals in the past because of how poorly he was treated. So we were able to enroll that young man and induce him successfully and get him to downstream treatment. And he has since completed care and is doing really, really well, has his own apartment and a job, and is still in recovery. And then our second story comes from Dr. Jameson. And he said that the patient wasn't upfront that she had opioid use disorder, but he began to suspect it. And she was really reluctant to answer him, but he assured her that he was not going to judge or dismiss her, and to please be honest because he has the ability to help her. And her demeanor immediately changed, and she relaxed, and her body language was less defensive and more open, and asked what he meant. And he said, "We have Suboxone," and she began to cry, and says that she ran out of her Suboxone 1 week ago and has not been able to get back to her provider, and has been able to compensate with whatever she could get her hands on, but was running out and desperate. She was supposed to start a new job the next day and was terrified to lose it if she is still sick with withdrawal. So we were able to induced that patient successfully as well. He also provided her a bridging prescription, and we were able to get her to downstream care, and she was there that next day to start her job.
And Desiree, did you want to tell us maybe about some of the patients we've sent over to you and how they've done?
Sure, I'll tell you about one in particular that is a true success story. She came to us 2 days actually after being at the ED, and she was induced at the ED. She came to us, and I'll let you know a little bit about her clinical medical presentation. She was a young lady in her middle 20s, started using in her early 20s, and she was using a cocktail of crack cocaine, heroin, and fentanyl. IV, so her use, increased to IV use within 4 years of onset. She also had some legal issues that were going on along with child welfare issues. So she came into MAT services one day, and then she was admitted to residential services the next day. She went into residential. She completed 6 months of residential care, which she had access to psych services, employment services, all kinds of gender-specific care while she was there with us. She was also able to get employment towards the end of her residential care. She graduated from residential. She enrolled in outpatient care. She wanted to do this. This was voluntary. And she is currently right now successful in outpatient care, also successful in medication-assisted treatment. She has a child welfare case that originally her permanency goal was termination of parental rights, but now she's been able to fight that, and she's opened it back up and has visitation with her child, and she's going to be able to be a part of her child's life. And the best thing that she says right now about where she's at is now she's able to start work on her long-term recovery.
That's a great story, Desiree. And I think Samantha had a story she wanted to share with us as well.
All right, I'm back. Number one, I was a success story from there as well. It was great being there, and it's very comfortable, and they do a lot of meetings, and it's just really a good way to build foundation for the patients that we can get in there. Now, we also have a gentleman named Wanza, who was one of those patients who continued to come back. I think he came back about
8 times.
5 to 8 times. And every time I would meet with him, we would talk, and then finally he got into residential. Desiree, me, Heather, Jonathan, we were all fighting for him to get in there, and he's finally there. And I saw him the other day when I was dropping off COVID swabs to them, and he was like, Samantha, and it was just great to see him. He looks so healthy. Whoever helped him get on that path, thank you so much. He is doing great there.
It's definitely a joint effort between multiple physicians. I know Andrew saw him once, and then Jack saw him once, and Dr. Jameson saw him once. But yeah, and to that end, if you guys ever have any sort of impactful patient encounter where you would like to know the downstream outcome of how that patient is doing, please get with me or Samantha, and we would be happy to let you know how they're doing.
That's great. And I know we're over time. So just to wrap up, are there any other final thoughts from our community providers? If not, what I would like to do, at least just give a second for any faculty who have a question or a comment as well.
Jason?
Yes.
David Orban, I just want to thank you guys. This is just phenomenal to hear this. This has progressed so fast in the past 5 years. I just can't believe it. We're light years ahead of where we were 5 years ago. And I want to give you, I want to thank you and Jack and Heather from our program. You've just done a tremendous amount of work with this. It's really obvious. And my hat is off to you for being able to get in with Gail DeFrano. I've known her for a while, and I think it's to be able to join that national program is just phenomenal. I don't know anybody else in Florida who's doing what we're doing here. We go to the FSEP meetings, and I've tried to read on what they're doing, but I think we're way ahead of anybody else in Florida on this. My biggest concern And I know that Jay Reale and some of the folks from St. Joseph's and some of the guys from Advent Health were sort of originally in on this a couple of years ago, and it kind of dropped out in terms of this kind of delivery of healthcare in the emergency department. I'm interested in your thoughts on what we can do. We are sort of a laboratory right now. I look at what we're doing as a laboratory and getting out good work, and hopefully we'll do a lot of publications. But how do we start to diffuse this out into the community? Because I honestly think if you look at Pinellas County and Hillsborough County, the other hospitals are not doing a lot with this. And they have not sort of linked in with the network as far as I can tell. And that's from talking to Jay over at St. Joe's and from talking to some of our graduates at St. Anthony's over in Pinellas. I just don't think it's happened yet. When do we begin to diffuse this into the community to get it a little more widespread?
Yeah, thanks, David, for that. Just because of time, I'll just mention briefly some of the work around that, and well, we can talk more offline about it. But so I think we're kind of starting the scale up phase really at this point. We have been able to get a peer to St. Joe's now. That also, like we mentioned earlier, some of our prior residents have started to build out programs. The St. Anthony's program is enrolling patients into their MAT program. I'm Michael Sheehan over at PAR is doing some work over there with that group. So we are starting to be able to build out some of this, but that is, I think, Heather's goal is to scale all of this work, first test it here, hardwired here, really see what works, and then scale it up. And to that point, I think you're on it too, Dave. I have a meeting at 1:30 today that I've been put on another task force by the county with Jay Reale, which is, meant to scale up work like this across the county. So that work's going on. I know Heather sits on one of those advisory boards as well. So thanks for that, Dave. And thank you for I think you're right. That we're way ahead of where we were. And we're in the scale up phase, I think, now. David, thanks for the comments. David Broughton, thanks for the comments and the comments too. I appreciate that. And great, we'll definitely like to have you back for the alcohol pathway. I know we're way over time. Any other final closing comments from faculty or residents?
I would just add that, this is not, because it's changing so fast, we're not going to see this stuff in textbooks, and we're all kind of contemporaneously learning this together. So there's not attendings who have been doing this for 5 or 10 or 15 years. So residents, I would just say, feel empowered to help us all learn together at the same time, because we're all sort of foraging into this as a team.
And feel free, I know Adam does and a number of other people do, just send me a text message. If you have a patient and you're not really sure and you think they'd be a good candidate, just text me and we'll go over the patient together.
Well, great. I want to thank all of you. Oh, can you pop your number in there, Heather? You feel comfortable doing that? So I really do want to thank all of the panelists we had. We had, at one point I looked up, we had 66 people, I think, on the on this grand round. So that's an incredible, participation. And I think people were very engaged and participatory in this. So I really do appreciate all the feedback and comments and work from Jack and Heather and Samantha that went into building the PowerPoint and all that work. So we'll come back, if it's okay with you, Jim, in November or something, and do alcohol. I'm sorry we went a little bit over, but we will give it back to you. And I know people have to get to their breakout rooms for foundation. So thanks a lot to our guests, and really appreciate the good conversation. Thanks a lot.